Good evening, everyone. I'm Hiranya, medical student at St. George's University, Grenada. It is my pleasure to invite you all for this Sickle Cell Awareness webinar today. Being 19th June, we would like to raise awareness on sickle cell for World Sickle Cell Day. So this is the first webinar organized by Hiranya Medical Service. And today we have a very interesting panel and an experienced guest speaker. First, I would like to introduce and welcome our guest speaker, Dr. Vimal Kumar. He is a consultant for pediatric hematology, oncology, and bone marrow transplant at Dr. Rela Institute and Medical Center, Chennai, India. I would also like to welcome our other panelists, Dr. Devapriyan Johnson, who is a general medicine senior house officer at Kettering General Hospital in the Midlands, UK. Miss Vanshika Garg and Miss Aditi Gupta, who are medical students at St. George's University, Grenada. We aim to raise awareness to the public, our friends, family members, as well as other healthcare professionals about sickle cell through this presentation today. And this is for educational purposes. So if anyone has any signs or symptoms of sickle cell, please kindly take advice from a local doctor at the earliest. And in this presentation, we will try to keep our discussion as close as possible to evidence-based research that is taken from reliable resources. So we would like to first start with our youngest panelist, Ms. Aditi Gupta. Ms. Aditi Gupta has completed her pre-medical sciences successfully, securing a position in the Dean's List at St. George's University, Grenada, and she will be entering School of Medicine Term 1 in August 2021. She is a member of Women's Health in Students Against COVID. She has taken part in several activities and competitions and has won many awards. To say a few, she has secured a position among the top 5 participants in the Caribbean Examinations Council. She has also won third prize in Grenada Brain Bee Challenge. So over to you, Ms. Aditi Gupta. Please do enlighten us with your introduction to sickle cell and the importance of raising awareness.
Thank you so much, Hiranya, for your wonderful introduction. Good evening, everyone, and I thank you so much for this opportunity to be here. As we heard, this is to raise awareness for those who have or know someone who has sickle cell disease. Raising awareness always starts with educating the public about the basics. So let's begin. So where did sickle cell disease even come about? Research took me back to 1910 when Dr. Herrick had a patient with a declining respiratory system. As part of making a diagnosis, tests were ordered, such as a blood smear from tissues in the respiratory tract, which revealed unusual crescent-shaped blood cells, unlike the normal red blood cell, which will be discussed in a minute. The doctor termed this as a sickle cell, and more research confirmed that this is in fact a blood pathology. In the past few years, sickle cell disease has been most commonly among people of sub-Saharan Africa, South Asia, Middle East, and the Mediterranean. In the US, 1 in 500 African Americans and 1 in 36,000 Hispanic Americans suffer from this disease. There's no gender bias, as it's not a sex-linked disorder, and signs of a sickle cell disease start to develop in the first year of life and gets progressively worse. To give more context, here is a comparison between a healthy red blood cell and a sickled red blood cell. Notice the differences in the shape. Shape of the cell is crucial for the main function of a red blood cell, which is to oxygenate or perfuse bodily tissues. A normal red blood cell is a biconcave disc to increase surface area and carry more oxygen molecules. But how does a red blood cell even carry oxygen? Here is when hemoglobin plays in. This is a protein found in red blood cells with a heme molecule in each polypeptide to which the oxygen binds. Just for reference, I have included the normal plasma levels for hemoglobin, notably 13.5 to 17.5 grams per liter for males and 12 to 15.5 grams per deciliter in females. This is a variable number as we go through menstruation per month. Now we know the differences between a normal red blood cell and a sickle cell. But what makes the sickled red blood cell so pathological? Allow me to direct you all to this picture, which shows unrestricted and restricted blood flow. If we look carefully, the sickled cells are unable to pass through blood vessels smoothly and tend to clump up and block blood flow. The main feature of these cells, which cause them to clog vessels like this, is their sticky edges. These edges would come together most commonly at the junction where a large vessel bifurcates to smaller blood vessels, blocking blood flow to organs. A lack of perfusion can cause metabolic acidosis and many other conditions which can eventually lead to organ failure. This is called a sickle cell crisis or a pain crisis. And like the name suggests, many patients in a clinical setting complain of severe pain episodes when presented with this. Now, this image shows a common presentation of someone with anemia. Anemia simply means a lack or a deficiency in the normal amount of hemoglobin. So, as you can see here, to be specific, if we're talking about sickle cell anemia, the number of healthy red blood cells would decrease and the sickled blood cells would increase in this histological smear. So in a normal setting, a normal person with no anemia, this is what their histological blood slide would look like, with lots and lots of healthy, normal red blood cells. And if someone had anemia, you would only see just a few red blood cells. And in sickle cell anemia, you would see a few of these like this. And in the middle of all of these, you would see sickled crescent-shaped cells. So with sickle cell disease, patients may present with a variety of different symptoms like vision problems, jaundice, which is yellowing of the skin due to increased bilirubin, icterus, which is yellowing of the whites of the eyes. The patient's hands and feet can also be swollen. It's called dactylitis, and this is due to a lack of blood flow as a compensatory mechanism to retain as much fluid to balance the body's compartments. There's also increased vulnerability to infections, which will be discussed coming up. A taboo topic not talked about, but it is a very important symptom of sickle cell disease. It's called priapism. And this is when, usually seen in kids, it's a prolonged erection. So before I talk about how someone even gets sickle cell disease, I would like to first introduce some key terminologies, which I think is important to understand before we go on and talk about the genetic side of things. So simply put, a gene is a basic functional unit of heredity. It is made up of DNA in our chromosomes. And there are 2 copies of every gene in our genetic makeup. Genes can become pathological, meaning cause disease and be abnormal if they undergo mutations. And this is an example of what happens in sickle cell genes and cystic fibrosis genes, anything. A trait is also known as a carrier. This term is given to a phenomenon when an individual possesses only 1 copy of the abnormal or pathological genes. Remember that there are 2 copies of every gene. So if you have 1 abnormal, you are said to have the trait or you are a carrier. So an individual is said to have the disease, for example, sickle cell disease or cystic fibrosis, if they possess both 2 copies of the abnormal genes in their genetic makeups. That means both of their genes for that particular disease are pathological, abnormal, so they present fully with all the symptoms of all of the diseases. So humans are diploid organisms, as I just said, that they have 2 copies, which means that our chromosomes have 2 copies of the sickle cell gene. Sickle cell disease follows an autosomal recessive pattern of inheritance in which both copies of an abnormal gene must be present for the disease to manifest, like we just explained. A carrier would only have 1 copy of the abnormal gene. So in a hypothetical example, if I were to have sickle cell disease, that would mean that both my parents would be sickle cell carriers. That being said, the probability of 2 carriers to have a child with sickle cell disease is 25%, as you can see in this family diagram. There's 1 affected, 2 carriers, and 1 unaffected child. Lastly, it is very important that we are doing this, that more and more people are aware of this condition. Many don't even know that they are carriers or are affected by the disease. The CDC has partnered with organizations researching sickle cell disease so that they can help educate and raise awareness in society. And it's important that we as future healthcare professionals and existing healthcare professionals continue to educate people who do not know about this and allow more people to be empowered and go about their daily lives living with this. And I thank you all for listening. Thank you, Hiranya, for letting me speak. And that's it.
Okay, that was really good. Thank you so much, Miss Aditi Gupta. It was a very good introduction for all of us. So next up is Miss Vanshika Garg. Miss Vanshika Garg is pursuing her medicine at St. George's University, Grenada as well, and she'll be entering term 4 in August this year. She has completed her undergraduate studies in zoology in India and then did her double master's degree in biotechnology at University of Windsor in Canada. She's a very good singer. She's trained in Hindustani classical music and has performed in various stages. Being an all-rounder, she has won the Student of the Year award for her academic and extracurricular activities. So the floor is yours, Ms. Vanshika Garg.
Thank you, Hiranya, for having me here. It's my pleasure to be a part of such a valuable cause. Without much ado, I would like to start by elaborating a little bit more about the pattern of inheritance that Aditi was talking about, and would be briefly introducing the concept of consanguinity here. This term basically refers to the relationship between the two individuals with a common ancestor, such as in case of first cousin marriage. When such individuals reproduce, the risk of having a child being affected by an autosomal recessive disorder such as sickle cell disease are higher. This is a more common concept in parts of southern India, Japan, and Middle East, unlike the Western culture. So let's understand a little bit more about the sickle cell disease by talking about its various subtypes. With the goal of creating awareness to a larger group of people, I would be talking about the more common genotypic variations rather than going into details about the rare ones. Firstly, talking about HVAA, which basically depicts a normal individual with 2 copies of hemoglobin gene showing no mutations, whereas the ones suffering from sickle cell disease would receive 2 abnormal copies of sickle cell gene from each parent. This is due to a point or missense mutation, which basically refers to a single amino acid substitution from glutamate to valine. This is the most severe form of sickle cell disease, and such individuals, depicted by HVSS, would exhibit the symptoms and presentations associated with the disorder as mentioned earlier. Moving on to the third genotypic variation known as the sickle cell trait, which I'll be talking about in a little bit more detail. It's represented as HBAS, and such individuals have only 1 mutated copy of sickle cell gene and are known to be the carriers of the disease, like Aditi said. By carriers, what we mean is that they are heterozygous for the autosomal recessive pattern of inheritance and can pass on the trait to their future generations. They are generally asymptomatic, but during extreme conditions, they can experience what is known as the sickle cell crisis or the pain crisis. The extreme conditions that we are talking about are rare cases, such as those where there is increased pressure in the atmosphere, for example, scuba diving, or places where there is low oxygen levels in the air, such as military exercising, or high altitude, like mountain climbing, dehydration, even acidosis, or high carbon dioxide levels. In all such conditions, there is a risk of lack of oxygen in the red blood cells, which aggravate the symptoms such as shortness of breath. So if such individuals are aware of being a carrier, they can avoid such conditions and complications that are associated with it. So it's really important for people to be aware. Looking at the same example that we talked about, where both the parents are carrier of the disease, each time they have a 50% chance of having a child who's a carrier, and more importantly, 25% chances of actually having the disease. The probability is the same in case of both males and females, since it is not a sex-linked disorder. Okay, so let's talk about a more interesting concept which is observed in people who are carriers or say who have the sickle cell trait. This phenomenon is known as the heterozygous advantage, which is more commonly seen in parts of world such as Africa, Mediterranean, India, and the Middle East, which are more prone to malarial infections. By having an advantage, what we mean is that they are relatively protected against the harmful effects of the malarial parasite Plasmodium falciparum on the red blood cells. This is because of the sickle shape of the RBCs, which prevents the parasites from proliferating and rupturing the RBCs, hence decreasing the severity of the disease. In contrast, a person with sickle cell disease is actually highly susceptible to the lethal effects of the malarial parasite. Such patients have impaired splenic function or hyposplenism, which reduces the ability of spleen to opsonize and filter the parasitized RBCs. As a result, there is no phagocytosis of the encapsulated bacteria, thus making them susceptible to all kinds of infections such as those with streptococcus, Haemophilus influenza, and Plasmodium falciparum. Also, due to sickening of cells and reduced lifespan of RBCs, the anemia worsens, making it life-threatening and causing higher mortality rates overall. Lastly, I would like to talk about the available diagnostic and screening tools for sickle cell disease. Diagnostic can be done by simple blood tests, which can determine whether the parent carries an abnormal copy of the hemoglobin gene. Among the newborn screening tools, heel prick method has been used to obtain blood spots on a special paper, and smears are studied under the microscope to check the abnormalities in the shape of the cells. Amniotic fluid sampling, also known as amniocentesis, is another tool used prenatally where the sample is centrifuged and the genetic material is tested for glutamate to valine mismatch. Such early diagnosis and screening tools can be very helpful to reduce the complications and risk of infections. Parents can seek for genetic counseling when planning a pregnancy so that they can make a better informed decision and are well aware of the possible outcomes. That was my time, and thank you for being a patient listener. And I would like to hand it over to Hiranya now.
Thank you so much, Ms. Vanshika. It was a very good insight for us, and it kind of, brushed up all the basic concepts of sickle cell and the diagnosis part as well. So it was really good. Thank you so much. It is our great pleasure to have Dr. Vimal Kumar as our guest speaker for today. Dr. Vimen Kumar is a consultant for pediatric hematology, oncology, and bone marrow transplant at Dr. Rela Institute and Medical Center, Chennai, India. He did his undergraduate training from Madras Medical College, Chennai, and postgraduate training from SMS Medical College, Jaipur, where he was awarded gold medal for being the best outstanding student of the year. He underwent fellowship training in pediatric hematology oncology from Apollo Specialty Hospital, Chennai, and further special training at St. Mary's Hospital, Imperial College, NHS London, UK, under the Royal College of Pediatrics and Child Health, UK. He has more than 12 years of experience in pediatrics and 9 years of experience in the field of pediatric hematology and oncology. He has also a vast experience in managing all kinds of childhood disorders in India and the UK. He also manages a lot of blood related problems in children.
Hi, good day to everyone. Thank you, Dr. Hiranya, for the nice introduction and for inviting me to this wonderful webinar on sickle cell disease on account of World Sickle Cell Day. So in continuation with the above talks, I'll be speaking about complications and management of sickle cell disease. The objectives of my talk would be a brief clinical scenario, complications, both acute and chronic, management of sickle cell disease in terms of treatment and prevention, and a few words about COVID-19 and sickle cell disease. So this is a typical clinical scenario we come across in our day-to-day practice. For example, a 9-month-old child born to consanguineous parents presents with history of failure to thrive. On examination is found to be pale, icteric with a splenomegaly of around 3 centimeters. Hemoglobin is slightly on the lower side. So looking at the clinical picture, you suspect a diagnosis of congenital hemolytic anemia and you order for a hemolytic workup. So in the peripheral smear, you note lots of polychromasia, reticulocytosis, and Howell-Jolly bodies. Howell-Jolly bodies are typically found in asplenia or the functional asplenia, which we see in sickle cell disease. So the bottom slide shows the typical sickle cell RBCs. So in addition to that, we find high indirect bilirubin, high LDH, both consistent with hemolysis. You do a hemoglobin electrophoresis and we find that the sickle percentage of hemoglobin is around 80%. So all this fits in with the diagnosis of sickle cell anemia. So what are the spectrum of sickle cell anemia? So on one hand, you have a homozygous hemoglobin S or sickle cell anemia, where there are 2 abnormal hemoglobin S genes. So in these scenarios, we find that the sickle hemoglobin percentage is more than 80 to 90%. And the adult hemoglobin is literally absent. You can also find sickle cell associated with some form of thalassemias. You have sickle beta 0 thalassemia, where there is 1 hemoglobin S gene associated with 1 gene producing no beta subunit. So here we find again the sickle percentage is more than 90% and the adult hemoglobin is literally absent. So both these variants present with moderate to severe type of sickle cell disease. Then you have the milder variant, sickle beta plus thalassemia, where you have 1 hemoglobin S gene, which is abnormal. This is associated with 1 gene producing reduced amount of beta subunit. So here we find sickle percentage is roughly approximately 60 to 70%. And you have adult hemoglobin amounting to 20 to 30%. And there can be hemoglobin SC disease, where you have 1 S gene associated with 1 hemoglobin C gene. Here again, the hemoglobin sickle percentage is slightly on the lower side. So both the bottom 2 variants are associated with a milder variant of sickle cell disease. So this has been discussed. So hemoglobin S happens because of a single amino acid substitution in the beta globulin. This leads to polymerization of hemoglobin under hypoxic conditions, which again leads to distortion of red blood cells and vaso-occlusion. So these are the 2 spectrums of sickle cell disease. On one hand, you have a hemolytic picture. On the other hand, you have a vaso-occlusive crisis presenting with increased viscosities. Right. So how do you classify the clinical manifestations of sickle cell disease? It can be broadly classified into acute and chronic. So as you see in the list, sickle cell disease is a chronic debilitating disease which affects children right from their infancy till their adulthood. So it has a multi-system involvement. Almost all the systems in our body can be affected with sickle cell disease. So they can be roughly classified, as I said, into acute and chronic complication. So this cartoon describes the acute complications which are mentioned in the yellow boxes and the chronic complications which are mentioned in the green boxes. So some of the acute complications we'll be discussing today include acute chest syndromes, acute ischemic stroke, acute vaso-occlusive crisis, hemolytic anemias like acute splenic sequestrations and aplastic anemias. Some of the chronic complications include chronic neurocognitive dysfunctions, chronic hyperbilirubinemia, chronic kidney injuries, delayed puberty, avascular necrosis, chronic retinopathy, pulmonary hypertension, cardiomegaly, etc. Right. So majority of these acute complications of sickle cell can be classified under the term vaso-occlusive phenomena. So what all does it include? So it includes the most common presentation, which is acute vaso-occlusive pain, acute ischemic stroke, chest syndromes, renal infarction, dactylitis, myocardial infarction, priapism, and venous thromboembolism. So generally, children are asymptomatic during the first 6 months of life due to increased amount of fetal hemoglobin. By the time they turn into 6 months to 1 year of age, they start developing these symptoms of dactylitis. So dactylitis, otherwise called the hand-foot syndrome, is one of the earliest manifestations of vaso-occlusive crisis. Here, the children present with painful symmetric swellings of the hands and feet. Typically, the age group involved is 6 months to 2 years. And this happens because of the ischemic necrosis of the small bones of the hands and feet. So as they develop older, they again present with acute onset of severe pain, mostly involving the extremities. And older patients can present with pain in the chest, abdomen, or even back. And what the peculiar thing about this pain is, there is a recurrence of pain which tends to occur in the same site as the earlier presentation. And they can have variable presentation and frequency of these pain episodes. Data indicate that typically the pain episodes last throughout the life. Approximately 1/3 of these children have experienced pain episodes by 1 year of age, 2/3 by 2 years of age, and by the time they reach 6 years of age, approximately 90% of them have developed some form of vaso-occlusive pain crisis. So how does this occur? So these vaso-occlusive crises are precipitated by infections of any kind, bacterial or viral, exposure to cold weather, dehydration due to any causes, exertion, hypoxia due to any cause, acidosis, and even some form of stress can cause these vaso-occlusive crises. And more often than not, it is often a clinical diagnosis, and there are no objective diagnostic tests to diagnose them. So how do you treat them? Children presenting with acute vaso-occlusive crisis needs a rapid triage and assessment. There shouldn't be any delays in the emergency room. Triggers should be avoided, and we should start them on a good maintenance, approximately 1.5 times their maintenance fluid requirements, and they should be given appropriate analgesias. For mild episodes, we can begin with non-steroidal anti-inflammatory drugs like ibuprofen if they are not contraindicated. And in case of moderate to severe pain involvement, oral opioids or even intravenous opioids can be given along with NSAIDs. Acute chest syndrome. So this is one of the most serious and life-threatening complications of sickle cell disease and is the leading cause of mortality and morbidity. What are the causes of acute chest syndrome? It could be because of infections, most commonly Mycoplasma pneumoniae. It can also be because of thromboembolic fat embolisms or rib infarctions. So children with acute chest syndrome present with fever, tachypnea, chest pain, hypoxia, and hypotension. And often these symptoms, as you see, are indistinguishable from pneumonia. So hence, early diagnosis is very important. So how do you treat them? So basically, we need to cover them with appropriate intravenous antibiotics, most commonly third-generation cephalosporins, combination with macrolides like azithromycin. We need to give them appropriate hydration, good oxygen therapy in case if they are hypoxemic. We need to give appropriate pain control, right? And we should be very careful in giving opioids to these children because again, opioids can increase the risk of hypoventilation. So in addition to that, they might need a transfusion. So it could be either top-up transfusion or an exchange transfusion. We'll deal with the transfusion part sometime later. And if they have a recurrent acute chest syndrome, they should be started on prophylactic chronic transfusion regime in addition to hydroxyurea. And if there is no adequate response, they may be candidates for bone marrow transplantation. So the next complication, major side effect of sickle cell disease, which we see is acute ischemic stroke. So stroke is the leading cause of death and disability among children and adults with sickle cell disease. And this occurs most commonly due to blockage of the intracranial, internal carotid and the middle cerebral arteries. And they often present with acute hemiparesis, aphasia, seizures, severe headaches, cranial nerve palsies, coma, etc. Many often, they even present with subtle signs such as slight limp. So we often encounter patients coming to our OPD room and just presenting with a slight limping gait. And so we need to have a strong amount of suspicions to diagnose these cases early. How do you manage them? So we need to give them adequate hydration, and the initial therapy is often an exchange transfusion in an ICU setting, and we aim to reduce the sickle percentage to less than 30%. So this gives them a good symptomatic relief. And after acute clearance of these symptoms, these patients should be started on a long-term transfusion therapy to prevent recurrent stroke. And data indicate that there is an 80% of chance of recurrence of this stroke within 3 years of the first presentation if these patients are not started on a chronic transfusion regime. Splenic sequestration is again an uncommon but rapidly fatal presentation, typically affecting patients between 6 months to 24 months of age. And there happens a sudden pooling of large amount of blood in the spleen, and children present with massive splenomegaly, causing acute abdominal pain, nausea, and vomiting. And the hemoglobin here may drop to sudden lower levels, like even less than 2 or 3 grams per deciliter, leading to hypovolemic shock and death. Early recognition of this complication is very crucial, and these children can be saved with an urgent RBC transfusion and replenishment of their intravascular volume. Aplastic crisis is again an acute presentation where there is a sudden stoppage of RBC production, and this occurs usually associated with parvovirus B19 infections. Again, these children benefit from an early referral and early RBC transfusion. This is usually a complication which generally resolves after 10 to 14 days. Infection. Okay, so infection or sepsis is the major cause of preventable death in sickle cell disease. These children are vulnerable because they don't have a very good splenic function. They have a functional asplenia starting as young as 6 months of age, and they are most often encountered with encapsulated organisms like Streptococcus pneumonia, H. influenza, Neisseria meningitis, and Salmonella. There is also dysfunctional antibody and complement responses in sickle cell disease, and infections like pneumococcal sepsis can be lethal in 3 to 4 hours. So whenever these children present with high fever to the emergency room, they need to be evaluated immediately. Appropriate cultures need to be taken, and early starting of antibiotics is very much crucial to save life. Broadly, we can start them on third generation cephalosporins. In case meningitis is suspected, we can consider adding vancomycin. Again, we need to give them adequate hydration. Due to want of time, I'm not going into some of the long-term chronic complications of sickle cell disease. This slide summarizes a few complications. So the top left one indicates the avascular necrosis of hip. This is chronic leg ulcerations that we see. And this again, the long bone images show chronic osteomyelitis. And this is a picture of fundus which show chronic proliferative retinopathy. So how do you treat sickle cell disease? There are various arms of treatment. First is pharmacological. We'll discuss about that. Blood transfusion, hematopoietic stem cell transplant, and gene therapy. Right. Coming to pharmacological treatment, hydroxyurea. So this is the earliest medication which was licensed for the prevention of recurrent painful crisis. How does hydroxyurea act? It acts by increasing the fetal hemoglobin. It reduces the intracellular adhesion and improves blood flow. And this is effective in reducing the incidence of brain crisis and acute chest syndrome, thereby decreasing the morbidity and increasing the survival. This drug is well tolerated. Many studies have been done, and this is found to be safe in children as young as 8 to 9 months of age. So we need to remember the fact that optimal treatment may take around 12 months to have a response. So a minimum of 6 to 12 month trial on the maximum tolerated dose is recommended prior to discontinuation for failure to therapy. Okay. And the other important thing we need to remember when a patient is on hydroxyurea is we need to monitor their white blood cell count and platelet count every 2 to 4 weeks, because these patients can have cytopenias, and we need to temporarily halt the drug when they encounter any cytopenia. So the indications for starting hydroxyurea in children aged 9 to 42 months, we need to start regardless of the clinical severity to reduce the complications, to prevent the complications from occurring. In children more than 42 months, these are the various indications. So if they have recurrent severe pain crisis or pain that interferes with their daily activities, history of severe or recurrent acute chest syndromes, if they have an abnormal transcranial Doppler, we'll come to that later, transcranial Doppler, how it is important for screening for stroke. If they have previous history of acute ischemic stroke, and if children have sickle nephropathy, chronic hypoxia, symptomatic chronic anemia, so all these are indications for starting hydroxyurea. So these are the two newer FDA-approved drugs. One is voxelotor and other is crizanlizumab. Voxelotor is basically an anti-sickling drug which stabilizes the oxygenated hemoglobin, and this has been recently approved by the FDA. The other drug is crizanlizumab, which is monoclonal antibody against P-selectin, and this is mainly has been shown to ameliorate pain in adults. Coming to transfusions, so blood transfusions in sickle cell disease can be either in the form of top-up transfusions or exchange transfusion. What is the goal of transfusion? To improve the oxygen carrying capacity of the blood. Second is to prevent complications relating to vaso-occlusion and hemolysis. So again, we need to understand there are limitations for transfusion. One is iron overload, the other is risk of viral infection. So we need to regularly screen them for these. So these are the various indications for top-up and exchange transfusions. I won't go into the detail, but broadly speaking, simple or top-up transfusion is needed whenever you need to increase the hemoglobin level of the child. For example, a patient presenting with aplastic crisis, splenic sequestration or hepatic sequestration, where the hemoglobin is very low, you need to top up by a simple transfusion to improve their hemoglobin levels. In conditions where the sickle cell hemoglobin need to be replaced with adult hemoglobin. So in these patients, the hemoglobin may or may not be low, but there's lots of circulating sickle hemoglobin. So we need to exchange the sickle hemoglobin with the normal hemoglobin. In those conditions, we prefer an exchange transfusion. Okay, so coming to bone marrow transplantation, otherwise called hematopoietic stem cell transplantation. So at present, we need to understand that this is the only proven treatment for sickle cell disease. Okay, so here the aim of doing a BMT is to replace the patient's bone marrow with a functional bone marrow from a HLA matched donor. Okay, so the first successful transplant for sickle cell disease was performed in the year 1984, and usually if the transplant is done from a matched family donor, the outcomes are very good, more than 80 to 90%. And again, the transplant needs to be done before 13 years of age. This is a very important point because the older the child, they have more end organ complications, and the chances of success of doing a transplant is very much reduced. So the recommendations are BMT should be done ideally before 13 years of age, before they develop any end organ complications. So these are the various indications for doing a transplant. If they have a recurrent stroke or a CNS events, if they have strokes with cognitive impairments, and they have recurrent acute chest syndromes, they have osteonecrosis of multiple joints, elevated transcranial Doppler. So these are the various indications which you can find in articles. And this is the overall success rate of bone marrow transplantation. As you can see, it gives them a more than 90% survival rate. So this is something which is really amazing. And this is a graph which shows that after doing a transplant, there are various parameters where you see significant improvement. For example, physical functioning, bodily pain, general health, social functioning, emotional functioning. So you find an improvement in almost all the aspects of life where the patient was previously suffering from. So there are some limitations to transplant because only 25 to 30% of children or adults have a sibling HLA match. So what do you do if you don't have a match? Again, we need to look at alternative donors like unrelated donor transplants, haploidentical or half-matched transplants. So these are also done nowadays with very good results. And 75 to 80% of otherwise eligible patients do not have a matched family donor. That is the sad reality. But again, if patients have end organ damage, they are also not candidates for transplant. And there are certain side effects associated with transplant. There are some toxicity associated with the drugs we give. There is a 20 to 30% risk of mortality. graft versus host disease, infertility, all these are barriers for doing a bone marrow transplant. But with the recent advances and the improved survival rates of transplant, even a unrelated or a half-match transplants can be successfully done for sickle cell disease. So these are the few articles on transplant. You could go through them when you have time. So this is a sweet boy whom we had done a transplant. So this boy presented when he was like 13-year-old from Nigeria, and he was having symptoms of recurrent stroke and vaso-occlusive crisis. And he did not benefit from hydroxyurea and blood transfusion, and he was a candidate for bone marrow transplantation. Again, unfortunately, he did not have any matched family donors, and we did not find any HLA matched donors in the unrelated stem cell registries also. So we decided to go ahead with a half-matched transplant. So his father was half-matched donate stem cells, and he underwent the transplant 5 years back and is now again symptom-free absolutely. So gene therapy is something which is very much for the near future. Lots of interesting data are coming up, lots of activities going here. So here what we basically do is restore a functional copy of the defective beta globin gene. So it can be either done by gene addition or gene editing. So these are the two methods by which they are doing, and currently lots of clinical trials are going on currently for gene therapy. Right. So more than treatment, we come to the more important aspect, which is prevention. So how do you prevent? So there are various levels of prevention: primary, secondary, and tertiary. Primary prevention is through public health education, and all these sickle cell patients and trait patients, they should be aware of their carrier status. We should offer them a preconception genetic counseling, and we should offer them screening for couples who are at risk. So how do we do prenatal testing? This is by chorionic villus sampling, which is typically done at 10 to 12 weeks of gestation, or with amniocentesis, which is done after 15 weeks. Whom to test? So we need to test anyone with a history of chronic anemia in the family, history of relative with a hemoglobinopathy, couples from extended families living in endemic areas, or parents who have an ethnic background. So these patients should be offered antenatal counseling and prenatal GIST testing. So this is a graph which shows the autosomal recessive inheritance pattern of sickle cell disease. So on the top left, you have patients, the parents are both having sickle cell disease. So obviously all of their children, unfortunately, will have sickle cell disease. When one parent has sickle cell disease and another has sickle cell trait, there is a 50% chance that their children can have sickle cell disease and 50% chance that they can be trait. So when parents are, both of them are traits, so this is the most common scenario we might see, then there is a 25% chance that their child can have sickle cell anemia, 50% chance that they could be absolutely normal, 50% chance that they could be sickle cell trait, and 25% chance that they could be absolutely normal. So secondary prevention is by newborn screening. So newborns are often healthy at birth, and they develop symptoms only when their fetal hemoglobin declines, typically later in their infancy or early childhood. The goals of doing secondary prevention is to early recognition of affected infants, early medical intervention by starting them on hydroxyurea to reduce the morbidity and mortality, particularly from bacterial infections. So we need to start them on prophylactic penicillins. We need to give them vaccination. So I'll discuss about that soon. And there should be institution of regular and ongoing care should be ensured. And we should ensure access for families to accurate information about diagnosis, clinical features, treatment options in the coming years. So all these children diagnosed with sickle cell disease should be started on prophylactic penicillin as young as 2 months of age. So this is to reduce the risk of pneumococcal infection due to functional asthenia, and erythromycin is an alternative for penicillin. They need to be started on folic acid supplementation and immunization with the following vaccines, mainly PCV13, the H influenza V vaccine, meningococcal V vaccine, annual flu vaccinations, and pneumococcal PPV23 vaccination. So these are mandatory vaccines in patients with sickle cell disease because they have a functional asthenia. Coming to screening, So children with sickle cell disease should be offered an annual transcranial Doppler. So why do we do transcranial Doppler? To detect any early evidence of ischemic stroke or to identify patients who are at risk of having ischemic stroke. This should be started right from 2 years of age until at least 16 years of age. And these children can have ischemic retinopathy, so they should have an annual retinoscopic examination beginning at 10 years of age. They can have renal disease. There should be annual screening for microalbuminuria by the time they reach 10 years of age. And echocardiogram also is recommended every 2 years, right from 10 years of age, to screen for pulmonary hypertension. So this is a slide which shows the importance of transcranial Doppler and how it is important and what are the recommendations for follow-up. I wouldn't go into this, looks slightly complicated, but just do remember that if the transcranial Doppler velocity is more than 200, you're at high risk of having acute ischemic stroke, and you should be on a regular transfusion regime and periodic regular follow-up. So just a few points to take home. What are the red flag signs? So these are the patients, you need to act upon as soon as they reach the ER. So if they have a fever, a high-grade fever of more than 101 for the reasons we discussed, if they have significant respiratory symptoms like severe cough or shortness of breath, chest pain, again, this indicates acute chest syndrome. If they have a sudden enlargement of spleen, which indicates a splenic sequestration, if they have severe abdominal pain or increase in jaundice, any neurological symptoms, even if it is transient, because it might indicate an impending stroke. And if there is any significant increase in pallor, fatigue, or lethargy, if there is priapism, which is occurring for more than 4 hours, if there is pain, which is inadequately relieved by home medication. So these are the red flag signs which we need to keep in mind. Again, a few recommendations. Administer prophylactic penicillin. So as we discussed, it should be started early until at least 5 years of age in all children. We need to screen the children for transcranial Doppler. Again, this was discussed right from 2 years of age. And initiate treatment with opioids. Early treatment with opioids for pain control is again very important. Hydroxyla therapy right from 8 to 9 months of age is again very crucial in preventing lots of these complications. Yeah. And the most important point regarding bone marrow transplantation, it is most useful if it is done before 13 years of age and before the end organ damage develops. Right, so few words on COVID-19. So how this has impacted patients with sickle cell disease. So this was a recent publication in Blood, which shows that patients with sickle cell disease unfortunately had 2 times the increased rate of hospitalization. I mean, roughly 2 to 3 times increased rates of pneumonia and developing acute chest syndromes. So this was not seen with patients with sickle cell trait. So it's only for patients with sickle cell disease. And as you can see from this graph, compared to a normal population and sickle cell trait patients, sickle cell disease or sickle cell anemia patients have significantly more incidence of death, both within 14 and 13 days, more incidence of hospitalization, more incidence of venous thromboembolisms, ARDS, etc. So this is something which was very unfortunate. Okay, few question answers that I just gathered from internet. With regard to COVID-19 and sickle cell disease. So how should I evaluate respiratory symptoms in children and adults with an active COVID-19 infection? So basically you need to differentiate whether it is acute chest syndrome or a COVID pneumonia. So we need to have a low threshold for imaging because both the conditions have similar presenting symptoms, and early referral to a tertiary care center is very important. Should I change use of my exchange transfusion for neurological acute symptoms suggesting a stroke? Again, what we are aiming at by doing an exchange transfusion, we need to keep the sickle percentage to at least less than 15%. So ideally the recommendations are 30%, but if you could reduce it to 15%, it gives them a better duration of symptom-free period. So we need to aim to give them a proper exchange transfusion, reducing the hemoglobin sickle percentage to less than 15%. Should I change my use of exchange transfusion or regular blood transfusion for primary and secondary stroke prevention? Again, if you are in a center where there is no blood shortage, then ideally no, you need to continue them on regular transfusions. If there is blood shortage, then again, you could consider them on starting treatments like hydroxyurea, which could prevent a lot of these complications. How should one balance risk of hospitalization for acute painful vaso-occlusive crisis management versus risk of exposure? Okay, so many patients ask this question that their child has pain or have significant pain in their extremities and they have not responded to NSAIDs, which is the first line of management, and they are very often hesitant to come to the hospital for fear of acquiring COVID-19. So again, if you have facilities, you could probably consult them via telemedicine and consider early use of oral opioids. Oral morphine tablets can be given at home, which the patient can take at home. Should a child or adult with severe COVID receive therapeutic anticoagulation? Again, the recommendations are as per the guidelines of COVID. There you can have prophylactic doses instituted as per institutional practice. Should children or adults with sickle cell disease and COVID receive COVID-19 disease ameliorating therapies? Again, there is no contraindication. Dexamethasone can be given, and dexamethasone can be, has been found to be life-saving in patients present with hypoxemia. So again, there are no contraindications for that. In patients who cannot receive dexamethasone, again, you could go ahead with treatments like remdesivir and baricitinib. And recently, the monoclonal antibody treatments has also been used, and again, they can be easily used for sickle cell disease also. There are no absolute contraindications for that. Is there any specific guidance you are giving patients that are considering transplantations of gene therapy? Again, you should go by the local pandemic status. So if you have if you are in an area where COVID is relatively well controlled and you have lots of population who are vaccinated, you could safely go ahead with transplant. And we need to make sure that both the patients and the donors should be fully vaccinated before starting the VMT process. Should I adjust dose of sickle cell disease medications given the COVID-19 threat? Again, absolutely no. You need to continue all the medications like penicillin and folic acid. Should approved COVID vaccines be administered to sickle cell patients? Absolutely yes. CDC has designated sickle cell among the medical conditions which are at high risk for severe COVID-19. So, as per the recommendations, these vaccines can be given. So these are my references. You could go through American Society of Hematology guidelines, which are very standard guidelines for sickle cell disease. Thank you.
Thank you so much, Dr. Vimal Kumar, for your very informative and wonderful presentation. Being medical students, we learned a lot from this presentation, and I'm sure that others who are watching also are finding it really helpful. So we have been posting on social media that we'll be doing a webinar on sickle cell. And if anyone has any questions, they could send it to us so that we could direct it to our expert doctors today. So yes, Dr. Vimal Kumar, I would like to ask you a few questions from that. So the first question, what is the difference between sickle cell anemia, sickle cell disease, and sickle cell trait?
Yeah, that's a good question. What is the difference between sickle cell anemia, disease, and trait? So, as we have discussed, usually what happens in sickle cell trait is it is a heterozygous state. You have one set of genes which are absolutely normal, and there are one set of genes which are HBS genes. So basically, it's not a very severe disease. It is only a carrier form of the disease. So you have a adult hemoglobin of approximately 50 to 60% in sickle cell trait. And because the adult hemoglobin is that much, sickle percentage is only approximately 30 to 40%. And the sickle cell trait do not generally manifest with symptoms, unlike sickle cell anemia. So sickle cell trait, as you see, it's a heterozygous state and it's a milder form of the disease. Sickle cell anemia, as we discussed, again, the sickle cell percentage is more than 80 to 90% because it is a homozygous state. Both of the sets of genes are harboring the sickle mutation, and the adult hemoglobin percentage is literally 0. So sickle cell anemia patients again do manifest most of these manifestations of sickle cell disease. What is the difference between anemia and disease is basically sickle cell anemia refers to a hematological problem. These patients may not experience the end organ manifestations. Sickle cell disease, you have the end organ manifestations. So whenever a sickle cell patient has end organ manifestations, he has acute chest syndromes, he has vaso-occlusive crisis, we call them as sickle cell disease rather than sickle cell anemia. Thank you.
Oh, okay. Yeah. So we'll go on to the next question. What causes the sudden death in patients with sickle cell disease?
So as we discussed in the red flag signs, most of the acute complications that we had discussed can cause sudden death. So if you look at data, like in some countries in Africa, approximately there is a 30 to 40% risk of mortality before these children reach 5 years of age. So it can be a very devastating condition. So lots of factors predispose them to sudden death. Most importantly, sepsis that we discussed because of the functional asplenia, and children presenting with high-grade fever should be started early on antibiotics. Some of the other indications, other causes for sudden death include acute stroke, acute chest syndrome. So most of these acute complications that we had discussed, acute splenic sequestration, can all lead to sudden death. If you look at the older population, adults, then majority of deaths are due to pulmonary hypertension. So this is one of the chronic complications of sickle cell disease. Pulmonary hypertension, cardiomyopathy, thromboembolism. So all these are risk factors for having a sudden death. Thank you.
Yeah, this is very informative. And the next question would be, what triggers sickle cell crisis?
So this we had discussed in one of our slides. So infection, any form of infection, be it bacterial, viral, exposure to sudden cold weather, dehydration due to any cause, if they have any exertion due to any cause, if they have hypoxia, acidosis, or even stress. So all these are factors which could trigger a sickle cell disease, and it is important that we counsel the patients among these triggers because they should avoid these triggers as much as possible. Yeah, so these are the factors which we need to counsel the patients accordingly. Thank you.
Thank you for your detailed explanation. I think even one of our panelists had covered this topic briefly in the introduction. So we'll move on to the next question. To reduce the incidence of sickle cell, which two gene types should not marry?
Okay, so again, a very good question regarding marriage. So see, it's important it's easy to counsel a sickle cell patient regarding marriage because the sickle cell patient already knows that he has the disease right from their childhood. So obviously, it's easy counseling them. But the challenge in antenatal diagnosis and in prenatal testing is to identify the sickle cell trait groups. So because the sickle cell traits are often asymptomatic, they've not had these complications, many of them do not suspect that they have a sickle cell trait. So what happens if a sickle cell trait patient marries another sickle cell trait? Again, as we discussed, there is a 25% chance of them having a child with sickle cell disease. So it is important that we identify the patients with sickle cell trait early, advise them that they should not marry another patient, or his partner, his or her partner should not have sickle cell trait. So that is the most important antenatal or genetic counseling that we could give them.
Okay. And the last question that I have is, what happens if sickle cell is not treated?
Okay, again, very practical question. What happens if they are not treated? See, again, so this is a condition which needs early treatment. Lots of these complications can have devastating effects. So sickle cell disease is it's a chronic debilitating disease which starts often in infancy and goes on till adulthood. So it is important that we start them on early treatment with hydroxyurea, which prevents most of these symptoms. If there are indications for starting blood transfusions or exchange transfusion, that should be started. Without treatment or without, having them untreated, unfortunately, we may not be able to save around 20 to 30% of population before even they reach 5 years of age. So it is important to identify these patients early, diagnose them early, start them on appropriate medications and keep them on a regular follow-up, which is very important. Thank you.
Oh, okay. Yeah. Thank you so much, Dr. Vimal Kumar. You clarified all the questions that came to us, and it was very much elaborated. I'm sure being a specialist consultant, you will have a lot of work in the hospital, including bone marrow transplants. But we really are grateful and appreciate you for all your time and effort for preparing and sharing wonderful tips with us. And we're extremely happy that you were able to join us. Thank you so much, Dr. Vimal Kumar. Next, I would like to introduce you all to Dr. Devapriyan Johnson, who is the General Medicine Senior House Officer at Kettering General Hospital in the Midlands, UK. He graduated from King's College London in 2018 and completed his rotations in hematology and pediatrics. So your first question would be, how long can a person live with sickle cell disease?
This question is more towards the life expectancy of patients with sickle cell disease. Early studies, early literature on life expectancy is not so favorable for pediatric population. So the pediatric mortality used to be very high. But I'd like to point towards a study that was published in 2013. This was a large-scale statistical study that looked into persons' mortality with sickle cell disease. So they looked at 16,000 sickle cell-related deaths, and they worked out the mean and the median age of death for male and female patients. So they found out that the mean age of death from 1979 to 2005 to be 33 for men and 37 for female, and median age of death was 38 for men and 42 for females. We can compare this with life expectancy of cross-continental Africa, let's say, which is 62 for men and 67 for female. And of course, with the first world and developed countries, such as America, UK, and Australia, the life expectancy is 80. So you can clearly see that comparing the values of patients with sickle cell disease being near the 40s and people who don't have sickle cell disease being near the 70s and 80s, that there is a real clinical significance in raising awareness of this disease. And there is also a positive note from the study that they found out that pediatric mortality has been decreasing 3% each year for every year that was studied. So this goes to show that the modern medicine is working, and like we as medical professionals should work towards pushing for more and more clinical trials and also implementing better clinical care and guidelines for healthcare staff for treating patients with sickle cell disease to prevent pediatric mortality, to increase average life expectancy, and also to improve quality of life for patients with sickle cell disease.
Okay, wow. Actually, that's very interesting. So yeah, it's very important, as you said, to raise awareness so that more people are aware. So thank you for that. And your next question that came across would be, what kind of challenges might patients with sickle cell face in daily lives?
Sickle cell disease affects quite a lot of different organs and quite a lot of symptoms that come with it. The main symptom that both patients and the healthcare staff who looked after patients with sickle cell disease agree is the pain. Severe pain, agonizing pain. We'll talk a bit more about the pain later, but I would like to focus a bit more on the anemia side of symptoms to answer this question, because I'm aware that we'll be talking about pain later on as well. So people with sickle cell disease will start to have signs of the disease as early as first year of life, around after the five months of age, five months of age as well. So symptoms and complications of sickle cell disease can vary from person to person. So it's pretty much a spectrum. Some people have severe symptoms early on in life, which can be very debilitating, and some people tend to live a longer life without much of a symptoms and have milder level of symptoms. The reason why infants don't show symptoms at birth is because of fetal hemoglobin. Fetal hemoglobin protects the baby against baby's hemoglobin from sickling. When the infant is around 4 to 5 months, the baby's fetal hemoglobin is replaced by sickle hemoglobin. And this causes the red blood cell to begin to sickle. As the hemoglobin and the red blood cells get more and more sickled, the suffering of the patient become more and more pronounced, and the anemia becomes more and more worse. The main symptoms of anemia. So anemia simply means low level of hemoglobin in the body, in the blood system, intravascular system. With low level of hemoglobin, you have decreased oxygen carrying capacity. So your end organs will not be able to have enough oxygen, which means you won't be able to convert and make use of aerobic respiration and convert that to energy. So in order to meet the demands of the oxygen delivery, your lungs would start to breathe more and more heavy. So this would present as tachypnea. And for patients, they would complain of difficulty in breathing or shortness of breath. And heart would also be put under pressure in order to meet the demands of the end organs, to meet the demands, oxygen demands. So heart would pump harder and faster, so contractility would increase, resulting in tachycardia. So patients would experience symptoms of pounding, heavy chesting, chestedness, and also palpitations. If the brain is deprived of oxygen, the patients will have symptoms of dizziness, irritability, lightheadedness. This can even get worse and progress if the patient didn't receive high flow oxygen right away into coma and seizures, and even results in death. And if the end muscles, so large muscle groups such as biceps, triceps, quadriceps, posterior chain, and abdominal muscles, if they're oxygen deprived, then the patients would present with fatigue, tiredness, and lethargy. So these are all mix of symptoms that someone with sickle cell disease, even if they're not going through crisis, can still have non-crisis symptomatic days and have all of these challenges to overcome throughout their days. In addition to all of these symptoms and signs, patients can also have slowed growth and delayed puberty. These sort of things can make life really difficult for patients throughout their adolescence and early adulthood. Another important thing to mention is some of the early signs and symptoms that I mentioned about this tachycardia, dizziness, irritability, and shortness of breath. All of these can mimic anxiety and panic attacks. So patients often report negative experiences from healthcare staff in acute care settings because more often than not, their symptoms are mimicked by these other conditions such as panic attacks. So healthcare staff may not have provided adequate early analgesia and painkillers. So that's something for us to be aware as healthcare professionals. In my own personal experience, working with adults and children with sickle cell disease, they always express that they go through more symptoms that they actually come and present during the crisis times. So we as healthcare staff, what we see in terms of symptoms that patients with sickle cell experience is merely the tip of the iceberg. And whilst we are on this, it's also important to acknowledge parents and carers of people who look after patients with sickle cell disease, especially the psychosocial implications and challenges that they face looking after someone with sickle cell disease.
Wow, that's a really good insight you had given us. So thank you for that, Dr. Johnson. And your next question would be, what steps should be taken during sickle cell crisis so that you could reduce pain? And yeah, I think you mentioned that you'll be referring to that like in this question. So
yeah, so these are some of the preventative steps that I'll go over. So pain, why do patients with sickle cell disease experience pain? So Aditi and Vanshika, they previously mentioned during their talks about the pathophysiology of the blood vessels, during their bifurcations, the sickle cells can clog up and block these blood vessels. And this is the main reason why the patients can experience sudden onset of severe, excruciating, agonizing pain. And the pain in itself can be mild, moderate, or it can be extremely severe, and it can last any length of time. There are simple steps that we can take to prevent and reduce the number of pain crises. The main advice that we tend to give from public health point of view to general public and patients with sickle cell disease is to stay hydrated. So make sure you drink a lot of water, stay hydrated, and avoid drinks which have caffeinated, high caffeine contents and stimulant drinks. So we know that these drinks are weak diuretics, which means they make you pee more. And once you urinated a lot, you are more likely to go into dehydration. So avoid caffeinated drinks, stay hydrated. So that's the first step. The second is to make sure you maintain a good core body temperature. So make sure you're not too hot or too cold, and maintain an optimum body temperature. And the other steps could also include avoiding situations that have low oxygen levels, and also avoiding high altitude exposure to high altitude as well. So this including going for flying, mountain climbing, and cities with high altitude. And situations where you might be exposed to low oxygen levels. So this includes extreme physical exercise and strenuous activities, such as going for a military boot camp or training for an athletic competition. Most pain that patients with sickle cell disease experience can be managed with NSAIDs. So this include ibuprofen or aspirin over the counter, including paracetamol. However, when the symptoms become moderate, when the pain becomes a bit more of moderate level, patients might need regular prescription of opioid-based medications such as morphine. If the pain is severe, then the patient will require admission so that they can get more intense treatment and painkillers. If you're thinking of doing strenuous activities, especially if you are thinking about preparing for an athletic competition or any kind of other strenuous activities, these are some of the ways that you can help prevent painful crisis. First step is to build your endurance gradually through designed training programs. Make sure you can tailor these training programs to your needs and not just follow any generic training program out there. Discuss with your coach or discuss with your physician as well. And don't go all out. Avoid being overly tired and being out of breath. And if you're experiencing tiredness, being out of breath, if your heart rate's very high, if you're feeling weak in general, stop your activity right away and seek support, seek medical attention. Manage other medical conditions. So if you have sickle cell disease, of course, there's some literature that you can avoid malaria, but you can still have other medical conditions. So make sure you visit your physician and have a general checkup to find out other medical conditions are diagnosed and managed appropriately. Let's say, for example, you have asthma. Exacerbation of asthma can also worsen the sickle cell crisis. So managing asthma and managing other underlying conditions such as that is very important. And I can't emphasize this point enough. If you experience any symptom, seek medical attention right away. If you're feeling unusually ill, just seek medical attention. Do not hesitate, do not hold back. Seek an appointment with your physician right away.
Yes, definitely, Dr. Johnson. So the next question would be, does the symptoms of sickle cell disease worsen with age?
Interesting question. Age in itself is a non-modifiable factor. Compared to other factors that we can control, age is not one of them. And just like any other chronic conditions, such as ischemic heart disease, diabetes, sickle cell disease is also a condition that progresses over time. In order to discuss the age and its relationship to the sickle cell disease, I would like to break it down into firstly the children, secondly the adolescents, and thirdly the older adults with sickle cell disease. The adoption of neonatal screening, the use of prophylactic penicillin, prevention of stroke have actually improved pediatric and child mortality, and whose lifespan is now extended well into their adulthood. If you've mentioned about the median age of death for adults going all the way to 40s. Adolescents and young adults with sickle cell disease likewise need to manage both their disease, the healthcare system, the transition from the pediatric team to the adult sickle cell care providers, and also whilst being independent, whilst trying to study and find work. These are some of the challenges these adolescents face. And with older adults with sickle cell disease, every time they have a sickle cell crisis, the body goes through, or the organs go through a severe assault. So they're more likely to pile up more of comorbidities and organ failures along the way. So older adults with sickle cell disease are more likely to have other comorbidities and past medical history of other conditions. There is a study, there's an epidemiology study called the PISCES project, PISCES, that stands for Pain in Sickle Cell Epidemiology Study. It's quite interesting. So they surveyed 232 patients, younger and older patients with sickle cell disease, and they particularly looked into comorbidities, pain, utilization of healthcare, and psychosocial well-being, and they directly compared a young person with sickle cell disease with an older person with sickle cell disease. And quite rightly, they pointed out that younger adults have reported fewer comorbidities such as ischemic heart disease, hypertension, rheumatic disease, lung disease. All these things are less in younger patients. However, they've noted that the pain that was reported by the younger person and the older person is indifferent. And the younger adults did not report less pain or better psychosocial functioning compared to the older adults. So in essence, you've asked the question whether the symptoms of sickle cell disease worsen with age. Symptoms of sickle cell disease, such as symptoms of anemia and all the other symptoms, can be worsened by comorbidities for an older adults, worsen with age. However, the pain that they experience during crisis in itself is indifferent according to this survey.
Wow, okay. Yeah, I think, this is a very informative thing that you said. And thank you so much, Dr. Johnson, for this wonderful Q&A session. We got a lot of information from you, and we appreciate your time and the effort you have taken. And we're very happy that you joined us today evening. So thank you so much.
Thank you, Hiranya, for raising awareness of sickle cell disease and empowering people with sickle cell disease and people who provide care for them, the parents who look after their children with this debilitating and fatal condition, and also to educating your peers and medical students and healthcare staff as well. It's my pleasure to join you guys. It's a great set of panel. Hope this message reach as many people as possible and increase the awareness of sickle cell disease.
We are pleased to have all of your participation today in the Sickle Cell Awareness event organized by Hiranya Medical Service. And if anyone has signs or symptoms of sickle cell, please consult your local doctor. And after seeing this video, I'm sure anyone with sickle cell would feel more confident and, overcome the obstacles that come ahead so that they could excel in their career and basically be warriors against sickle cell. So to end, I would quickly like to say a few words about Hiranya Medical Service. This is a YouTube channel that I'd opened recently in order to do some of the charity work and also, talk about medical topics like how we're doing sickle cell awareness this week. So if you go to our playlist, you will be able to see whatever projects I've done so far. So please do subscribe to this channel, click the bell icon button so that you'll receive instant updates about the future events and support us as always. Thank you so much.